Okay, we'll just give it a few moments and we'll get going. Okay, why don't we just get going? So picking up from where we were last week, I'll just remind, we'll sort of start again when we're thinking about, make this bigger. You can see that okay, is that right?
Yep.
Yep, good, thanks. All right, so again, when I think about tachycardia mechanisms, I think about in my own mind's eye, I look at the heart from the top to the bottom, and you can use whatever mechanism you want, but the key goal is to not, forget to think about things. So clinically, I would separate most arrhythmias in children to automatic or reentrant. There's also a third form, which is triggered automaticity, but clinically speaking, I think these two are most useful in terms of thinking about tachycardia mechanisms. So at the level of the sinus node at the top of the heart, the obvious automatic, I'm not sure I would call it an arrhythmia, but would be sinus tachycardia. There is, in fact, a condition called inappropriate sinus tachycardia where someone is tachycardic all the time. It's very unusual, but does occasionally happen. When we're thinking about reentrant arrhythmias that affect the level of the sinus node, there is a condition called sinus node reentry where there is actual reentry within the sinus node, and it's characterized by a sudden onset and offset of tachycardia with a P-wave morphology that is exactly the same as sinus. It's a very rare disorder. I've seen it probably 2 or 3 times in my career so far. Moving lower down to the level of the atrial muscle, when we think about automatic arrhythmias, we're thinking about ectopic atrial tachycardia, which we discussed last week, or multifocal atrial tach, which is sometimes also referred to as chaotic atrial rhythm, where there are multiple areas, typically 3 or 4, that are firing at rates faster than the sinus node. And then when we're thinking about reentrant arrhythmias that affect the level of the atrium, clearly atrial flutter or intraatrial reentrant tachycardia is the most common, and then atrial fibrillation is also considered to be a reentrant arrhythmia. Moving lower to the level of the AV node in the His-Purkinje system, junctional ectopic tachycardia is sort of one of the most classic and most deadly of automatic arrhythmias that we manage. And then when we're thinking about reentrant arrhythmias that affect the AV node, we're thinking about predominantly AV nodal reentrant tachycardia, which is very common in children. It's the second most common cause of SVT after orthodromic reentry using an accessory pathway. In adults, AVNRT is the most common form of SVT. When we're thinking about atrioventricular reciprocating tachycardia, there really isn't any known automatic one, although I guess one could say that a Maheim fiber can have its own automaticity, which would be a form of AV reciprocating automatic arrhythmia. And then when we're thinking about reentrant arrhythmias, clearly any kind of accessory pathway mediated tachycardia, whether it would be Wolff-Parkinson-White syndrome or a concealed accessory pathway, could be a reentrant mechanism. And then finally, at the level of the ventricles, VT or VF is typically an automatic arrhythmia, but VT can also be reentrant, particularly in patients who've had a myocardial infarction and have scarring in their heart around which electrical activity can rotate. So that's sort of the main mechanism or sort of framework or model that I like to use to think about arrhythmias as you're looking at EKGs and of course looking at patients. Okay. So, today is just a very basic lecture. So this is we're going to get into the weeds on all of these topics as the year progresses, but I think it's useful for us all to start at one location and then we'll move forward. So now we'll talk a little bit about treatment of tachycardias. So, and we're talking about mostly chronic or definitive therapy. So, drug therapy in general for SVT is usually effective. And there are many different agents that we use. The most commonly used ones are things like digoxin, sotalol, procainamide, amiodarone, beta blockers, flecainide, and verapamil. I think those would maybe diltiazem should be on that list, but those are really the most common agents that we use. Um, and when it comes to treating um, arrhythmias, particularly SVT with antiarrhythmic agents, unfortunately, it's very much a trial and error situation. And this is very important when you're meeting families of children who we're admitting to the hospital or who are in the hospital and are being treated. Families and doctors need to be aware that every SVT or tachycardia responds differently to antiarrhythmic therapy, and so there are patients in whom one agent will be very effective, another agent will not. Some patients in which a very low dose of one medicine will be effective, then other patients where we need three medications to control it. There are various reasons why that is, but I think it's always important to sort of set expectations with families when you're starting an antiarrhythmic agent, particularly when they're being hospitalized, because although in a perfect world, we'd like to see it be a very brief hospitalization, typically for 2 or 3 days, there are times where the medication is ineffective and it needs to be adjusted. And sometimes it can take as much as 2 or 3 weeks to get that proper. And so, if you set expectations at the start, then families will not think that you're managing it inappropriately. Okay, so acutely, when we're talking about SVT, the most common agent is clearly adenosine. It causes transient AV nodal block. Typically, the half-life is measured in seconds. And adenosine, as you know, is particularly useful for AV reciprocating tachycardia, such as ORT or AVNRT, which are the two most common forms of SVT. And we talked about how it's a good practice in a stable patient to be running a rhythm strip while you administer the agent because the response to adenosine can be very helpful diagnostically in understanding what's wrong with a patient who's in tachycardia who you've never met before. Another agent that can be used is intravenous verapamil, which also causes AV nodal blockade. Today, it's not as commonly used for two reasons. The first is that adenosine exists now. For many decades, there was no adenosine. Adenosine really only became clinically available in the very late 1980s and early 1990s. Prior to that, anyone who had SVT would largely be treated with either verapamil if you were over a year of age, or honestly, they would usually give you high doses of digoxin, and it would often take hours for the tachycardia to terminate. IV verapamil, I will remind you, is not appropriate agent to be given in small infants because it's been associated in the past with cardiovascular collapse. It causes hypotension almost uniformly in everybody, but in babies, it can be very life-threatening. So never, ever, ever use verapamil in babies. I think in retrospect, probably this is a bit overstated, but at the present era, I think it would just be medical legally as well as medically inadvisable to use this agent in babies. But it certainly could be used in older children. Not used very often, but still very effective. Okay, so now we'll talk about chronic therapy. So in infants, I think it would be fair to say that the most common agents that are used are either digoxin or beta blockers. Digoxin is virtually never used beyond the newborn or early months of life because it's not an especially effective antiarrhythmic agent. You might ask the question then, well, why is it used at all? Well, it does seem to work well in infants with some, people have done studies looking at what's the best antiarrhythmic agent, and there have been studies specifically that posing beta blockers versus digoxin, and there really is no strong evidence that one is better than the other. And what you're going to learn as you practice cardiology is that most doctors tend to have their own practice pattern, and most non-electrophysiologists become comfortable with one or two agents that they use a lot, and so they tend to just lean on those. And there's nothing wrong with that. For example, when I was a cardiology fellow, I never saw a baby treated with digoxin for the treatment of SVT. And then in my first job, which was at Columbia, where I worked for a decade, all the general cardiologists use digoxin like water in babies. And it was very common, in fact, to use digoxin and beta blockers in combination. And there's nothing wrong with that. It's perfectly reasonable. I think I would say it's a little bit old-fashioned because there are better antiarrhythmic agents. But on the other hand, I think people who would use that combination would say they have great safety and efficacy with that. And why fix what's not broken? So anyway, digoxin causes AV nodal slowing. It also reduces atrial ectopy, which is the instigator of tachycardia in this patient group. And the dosing, depending on the size and the age of the infant, is between 8 and 14 micrograms per kilogram per day. Most references will say it's like, I think in preemies it's lower, it's like 3 to 6. But anyone outside of the premature time period, you can really go pretty high. And when I first started as an attending, I used to tell my senior partner, Alan Hordoff, it seemed like, why is everyone using digoxin? It seems to be a bad agent. And he said it was a great agent. And his argument was that I was using too small of a dose. Because if you look at the literature, or just pick up the Harriet Lane handbook or any handbook, you'll see that typically, they say that the dose is 8 to 10 micrograms per kilo per day, and that's what we normally use. But people who use a lot of digoxin will say that you need to go at higher doses if you're using it to treat SVT. We've talked last week that digoxin can also be used, although digoxin carries significant risk for an enhancement of the risk of sudden cardiac arrest in patients with WPW. There are many electrophysiologists and mostly general cardiologists who will use digoxin in WPW patients who are under a year of age on the theory that the risk of sudden death is lower in that age range. I personally don't do that. I don't think it's wrong to do it, but I just kind of feel like there's enough alternative agents that it doesn't make sense to use that if you have other options. Beta blockers, I think, are the most commonly used agents, certainly here at Mount Sinai for babies. It also reduces AV nodal slowing, causes AV nodal slowing rather, and reduces atrial ectopy. The most commonly used agent is Inderal or propranolol, and all small infants, and by that I would say anyone under 6 to 9 months of age, need to be monitored with their blood glucose levels after they start propranolol, at least the first 2 or 3 doses, which is why patients often need to be admitted to the hospital. Sometimes people will ask me, this question comes up at least once every 2 or 3 months, whether I would start antiarrhythmic therapy on a baby that was born who had fetal SVT. And this is an area where Barry and I sometimes disagree. He'll sometimes say, well, let's watch the patient. And my attitude has always been that I would rather treat the patient. There are many reasons for that, but one of the reasons is because if the baby goes home and then has SVT, the child will have to be readmitted to have their blood glucose levels checked. And so my attitude is if you're already in the hospital being monitored, why not just kill two birds with one stone? I guess the alternative would be just, well, being on medicine is bad, and if you don't have to be on medicine, that would be better. Okay. For children and adolescents, beta blockers are still used commonly for the treatment of SVT. They are effective about 2/3 to 3/4 of the time. The reason that you might say, well, that's not especially effective. Why do we use agents that we don't think have like a closer to 100% safety efficacy, or efficacy rather? And the answer is simply because we're treating a not, generally speaking, non-life-threatening arrhythmia. And if you have a therapy that is very low risk, and has a reasonable chance of working, in which the consequences of not having success are not super dangerous, such as treating an adolescent who can tell you if he or she's having SVT, it's probably reasonable to start that way. So and again, in terms of which beta blocker cardiologists use, again, tends to be very idiosyncratic. And as I often joke, you are a victim of your training. And so usually most cardiologists use whatever their attendings used when they were fellows, and they tend to continue to do it. So people typically in older patients will use more heart selective agents like atenolol or metoprolol. But you can use something non-selective like nadolol also. Any of them are reasonable. The goal really is to try to use an agent that's going to be well tolerated. And you would ideally like an agent that does not require more than once or twice a day dosing, because as you know, 3 or 4 times a day dosing is very challenging. Um, Calcium channel blockers can be used as well, although again, I would remind that we don't use that in the setting of WPW. Like verapamil is a classic example. One of the reasons we don't use that too often, though, is that verapamil has a fairly long, has a fairly short half-life. And so if you're going to use verapamil, typically people use a long-acting version of verapamil and it comes as a tablet and you can't crush up a sustained release capsule or tablet. And the lowest dose is too high for smaller children and young adolescents. So that's the reason why you're not seeing a lot of verapamil used, but it is used in adults and is generally effective. And then digoxin, generally speaking, is not really used in older patients very often. It's not wrong to use it, but probably would work about as well as a beta blocker. Digoxin, as you know, can cause nausea at toxic levels. It can cause your vision to appear yellow or green. So we generally don't use it very often, mostly I think because there's an acceptance that it doesn't work very well. But if you back when I was an intern in pediatrics in 1991, I saw lots and lots of children who were on digoxin because I think that was a very, very commonly used agent in the 70s and 80s when there weren't other antiarrhythmic agents, and it seemed to work okay. When things like digoxin and beta blockers and verapamil don't work, then we typically will up the ante and go to more potent agents. And we're going to have talks in EP conference on all these agents. So these are just sort of little back of the envelope comments on each of these. So sotalol, as you know, is a class 3 agent, which means it has potassium channel blocking. One of the things about sotalol a lot of people get wrong is they see the last syllables of the word allol, and they assume it's a beta blocker. Sotalol is a beta blocker. It's a very potent beta blocker, but it also is a class 3 agent, meaning that it is a potassium channel blocker and has the potential to cause prolongation in the QT interval. That is, in fact, part of how it works. And so it's much more than a beta blocker. And beta blockers, which we feel are generally safe to start in older children as an outpatient. Sotalol, we generally do not start as an outpatient. Now, there is a lot of debate about this. There are a number of papers in the recent literature suggesting that maybe in the right person, it could be started as an outpatient. But in general, in pediatrics, we start Sotalol as an inpatient. It does have a higher incidence of proarrhythmia, about 10%. But it is a lot more effective in general than some of the simple agents because it has more than one mechanism by which it's preventing arrhythmia. Flecainide, which is a class 1B agent, is also very effective as an antiarrhythmic agent, but it has a fairly narrow therapeutic index, meaning that the risk of causing arrhythmias is substantially higher and is not that far from the therapeutic dose. The other thing I'll mention here is this thing called the CAST study. Some of you may be aware of this. In the old days, by that I mean like I think probably around the time I was a medical student, this study called the CAST study came out. So as you may know, when an adult has a heart attack, the most common reason they die is from VT or VF. And after a heart attack, because of scars that occur in the heart, it's not uncommon that an adult will have lots of ventricular ectopy. And knowing, as adult cardiologists do, that ventricular tachycardia or VF is a common cause of arrest and death following a heart attack. In olden times, cardiologists would just kind of randomly choose different medications to treat the ectopy that they were seeing on Holter monitors in this patient group. And in the CAST study, they did sort of a retrospective assessment to see if they could figure out which agents might be most effective. And one of the things they discovered was that patients who were put on flecainide on average died more. And that in fact seemed to be associated with an enhanced risk for mortality. Now that there are many potential reasons why this may not be true, but the bottom line is it received a very bad reputation, and to this day, one would never put a patient who had known coronary artery disease on flecainide because of the concern of proarrhythmia as demonstrated in this very important so-called CAST study. Now, that has absolutely nothing to do with the patients in whom we are treating arrhythmias, but every once in a blue moon, if you put a patient on flecainide, you're going to get a parent who's going to tell you that they read that it can cause death and things like that. So you have to remind them that the majority of the literature on flecainide being bad, typically in patients that bear no resemblance to the child that you're treating. Amiodarone is also a class 3 agent, but really, I remember there used to be ads for amiodarone on the back page of JAMA and the New England Journal, and they used to say that it's the only agent with all four von Williams classification effects because it's a beta blocker, a calcium channel blocker, a class 3 agent, and so it really has everything in it. It's a very effective antiarrhythmic agent. This is a very important point, so everybody will get at least one question right on their board exam. It has a very long half-life. It's about 45 days. And because of that, this is the reason why when we start amiodarone, we start with very, very, very high doses of amiodarone because we're trying to, as rapidly as and safely, increase the blood level of this medication. So it's not uncommon. So the typical dose for SVT for amiodarone is 5 milligrams per kilogram per day. But it's not uncommon that we'll start someone on 10, 15, or even 20 milligrams per kilo per day in order to try and get the level up as quickly as we can. And because the half-life is long, we would typically observe a patient for a few days at least in the hospital. The good news about amiodarone is unlike a lot of these other antiarrhythmic agents like sotalol or flecainide, it actually has a very low incidence of proarrhythmia. Amio is thankfully a very safe agent acutely in terms of causing problems. Some of you may know the history of amio. Amio was actually initially introduced as an afterload reducing agent, and it was sort of incidentally observed that people had less arrhythmia. It has fallen out. It's obviously not used for as an afterload reducing agent any longer, but is used for this purpose. Now, amio gets a bad rap because it does have a very high number of non-cardiac side effects, including pulmonary disease, which is typically a long-term effect of being on it for years, liver and thyroid, which can both be affected relatively quickly, meaning within the first few months of starting it. It can cause discoloration of the skin, particularly if exposed to a lot of sun. So we always remind parents of patients who are placed on amiodarone to avoid direct sunlight or to use a lot of sunscreen. So this comes up not infrequently in babies. Of course, babies are supposed to be out of direct sunlight anyway, but it's particularly important in that patient group who are on amio. It can cause corneal microdeposits in the eye, which do not affect vision, but rarely it can affect the retina. And so it's generally recommended that people who are started on amio have a baseline eye exam. Most ophthalmologists that I've spoken to about this think it's a waste of time. We've sort of not done it very often in the recent past. I think mostly because of a belief that or the knowledge that stopping amio almost always causes a reversal of all of those findings in the eye. So if someone really were having eye issues related to amio, the treatment would be just to stop it. So these are areas that we would certainly get LFTs and TFTs in everybody who is started on it. And the most important reason, though, that we would not leave someone chronically on amio, and by that I mean more than 2, 3 years, is because it can cause pulmonary fibrosis, and that is not a reversible cause, a reversible side effect. And one time in my career, I took care of a patient who had hypertrophic cardiomyopathy with a defibrillator, and if she was not on amiodarone, she would have VT. And after she was on it for about 8 years, her pulmonary function test started to demonstrate low levels of fibrosis. And so she actually ended up having to be transplanted because she could not be controlled for her VT without amio, and we didn't want her to develop pulmonary fibrosis. So it's a concern, but it's almost always a very long-term concern. Most of the time, you'll notice that we don't like to put children on amio for more than about a year. And the main reason is because of the concern of these side effects, particularly the pulmonary ones. So amio is a terrific agent to get you out of trouble, but it's not a good agent for chronic therapy. Um, Despite the fact that the drugs work reasonably well, they're not a free ride, as we've been discussing. There are side effects from all of them. We just talked about some of them. Some antiarrhythmic agents can actually be pro-arrhythmic, that we've seen that, particularly flecainide can do that. We've already discussed how they're not uniformly efficacious. Of course, any drug depends upon patient compliance, which typically isn't bad in kids under the adolescent years, but a lot of parents sort of defer the administration of the medication to adolescents to give to themselves, and it's not uncommon that they are non-compliant. Of course, when it comes to antiarrhythmic agents, you're only as good as your last tablet. If you don't take your pill, you have the same risk of tachycardia as if you never were on it. And so pretty much you have the problem of needing to be on therapy chronically. And then when it comes to Wolff-Parkinson-White syndrome, depending on the agent you are on, it may not actually reduce the risk for sudden death. The other thing is that for certain arrhythmias, it's even less effective. This is an old study, but it's been reproduced many times, that's showing that if you have intra-atrial reentrant tachycardia, basically all antiarrhythmic agents only work about 10 to 30% of the time. At 24 months or 2 years, over two-thirds of patients who had IART had a recurrence. And the efficacy of all the different agents were no better than digoxin, which is really the rationale for why ablation has really come to the forefront as an important modality to treat arrhythmias in kids. And the benefit of ablation is simply that it is potentially definitive. And if effective, and it's not uncommon that, of course, drugs aren't needed afterwards. And even if it is not completely effective, there are many examples for complex arrhythmias where ablation may take a patient may not remove the arrhythmia, but may make it much easier to manage medically. And there are rare occasions where even postoperative patients have to go to the cath lab for ablation. And this is one patient who happens to be in the hospital now, who we ablated for ectopic atrial tachycardia following one of his stage surgeries. And interesting, and the reason we did that was he was extremely difficult to control medically. And he came back 2 days later with the same arrhythmia, but at a different focus. But that form of ectopic atrial tachycardia was very responsive to the medical therapy as opposed to the first focus, and so it was very effective clinically. Just some very simple technical aspects, and all of you will be involved with and observing a number of ablations, including today. And typically, we'll put a minimum of 4 or 5 catheters. It's usual that there's 1 or 2 cardiologists. Sometimes it's a cardiologist and an NP, as we sometimes do here. There's always a CV tech. In the present era, we usually also have a CARTO representative. And so we have catheters that are in the right atrium. We have a catheter in the coronary sinus, typically a catheter sitting across the tricuspid annulus, monitoring the AV node and the His, and then finally one in the right ventricle. And you need to have fluoroscopy, although increasingly people are trying to do this with the minimum amount of fluoroscopy. And there are even some laboratories that don't use fluoroscopy. And then we use a programmable stimulator, which is essentially a fancy pacemaker to pace the heart. And this is just a simple example of successful ablation of ectopic tachycardia. The radiofrequency current goes on, and you see that the tachycardia, in this case, speeds up and then it terminates, which is common when you're ablating ectopic atrial tachycardia. In similar vein, this is an example of a patient who had WPW and was also ablated successfully. Now, in general, radiofrequency ablation results are very successful. This is an example from a paper from, 25 years ago, almost 30 years ago, showing in Boston that they had very high success rates. Now, this is acute success rates for multiple forms of SVT. And when I prepared this slide like 10 years ago, our overall success rate for SVT ablation was about 94%. So normally when we're obtaining consent for an ablation, I'll normally tell families that the likelihood of success is going to be in the 90 to 95% range. And by that, I usually mean acute success. There are a number of risks associated with ablation, and these include bleeding, stroke, infection, injury to coronary arteries, heart perforation, stroke. And in that original study by Ron Tennell from 30 years ago, it occurred about 1.2% of the time. And I think probably it would be fair to say that about 1% of the time there are complications related to EP study. In the proper hands and with the proper precautions, thankfully, this can be mitigated. Um, you know, Now one of the most difficult ablations that we deal with are ablations of Fontan patients. This is an example of an old style Fontan where the right atrium would be anastomosed directly to the undersurface of the pulmonary artery. And you could imagine how complicated it would be to ablate someone like this because the atrium is so large. And of course, where the reentrant circuit is will vary from patient to patient. Thankfully, we don't do Fontans this way any longer, but there are now new complexities associated with not even being able to access the true atrium because of external conduits. But in general, when you're doing a standard radiofrequency ablation for IART, results are fairly poor. Initially, we didn't have 3D mapping, and so the arrhythmia-free incidence following an ablation using standard mapping for that was about 50%, which, as I've demonstrated to you, is a little better than antiarrhythmic agents, but still pretty lousy. And that was really one of the main rationales for moving to things like CARTO or Biosense to create an electroanatomical map, which makes it easier to visualize what's going on in the atrium and to target one's ablation. Additionally, another problem that we have had with ablation is that the atria of single ventricle patients can be very thick, particularly the old style Fontans. Some pathological studies show that the atrial thickness can be equal to that of the ventricle of some patients. And so not only is identifying the area to target with the radiofrequency current very difficult in a single ventricle patient because of the extraordinary degree of variability of where these circuits are. But once one has found it, you need to know that you are delivering a deep enough lesion to actually impact the tachycardia. And so this has been one of the reasons why irrigated catheters, which make deeper lesions, have become more commonly used for this. Additionally, catheters today also have the ability to measure the contact force, which has also been demonstrated to be an important factor in the likelihood of efficacy. It's thought that before contact force and before the use of intravascular ultrasound during some of these procedures, a lot of lesions that were being made were probably just being made in the blood pool, and we were fooled into thinking we were actually touching the endocardium with the catheter. But you can see that when you use a irrigated catheter, the lesion size is substantially larger. That will probably mean that in general, you will be more successful because you'll make a larger lesion. You don't have to be quite as precise. The downside, however, of irrigation is that it also causes a lot more injury to the tissue around the site of interest. And so, for example, you'll notice that when I do SVT ablations, I rarely use irrigation because I am worried that other structures like coronary arteries that are on the other side of the AV valve, particularly the mitral valve, could potentially be injured. Not as big a concern in bigger patients. Also, if you limit the amount of power you administer, it might be a lower risk as well. But generally speaking, this type of lesion usually works for SVT, but For IART, you usually need this. Another recent innovation in the last 10 years, actually more like 15 to 20 years now, is the use of cryoablation, which has sort of two major benefits. The first is that when the catheter freezes to minus 80 degrees Celsius, it becomes adherent to the endocardium. So you don't actually even need to hold the catheter anymore. It's literally stuck with an ice ball to the endocardium. So you don't have to worry that you're inadvertently going to move the catheter during the delivery of energy. So that's a nice feature if you are in an area where a millimeter or two of movement could cause an injury to something other than the target of your ablation. The other benefit is that the lesion size is a little smaller and it's more reversible, meaning that if you turn on cryoenergy and you see something you don't like, for example, you're burning near the AV, you're freezing near the AV node and you start to see heart block, generally speaking, if one turns off the cryo fast enough, meaning within a few seconds, it would be very rare to have a permanent injury to the tissue. So it has the nice feature when ablating things near the AV node to being able to see what would happen with RF without actually causing a permanent injury to the surrounding tissues. So some families have asked me the question, why would you not use that all the time? Because that seems to be a really nice feature. It is a nice feature, but it is unfortunately two sides to the sword, which is that it doesn't work as well. For the same reason that it makes a smaller lesion and is generally safer, it also has a higher incidence of recurrence. Now, people who use cryo all the time will tell you that if you know how to use it, if you use a big enough tipped catheter, which is typically larger than an RF catheter, if you put enough lesions in, that you can have a similar efficacy rate with greater safety. People who don't like cryo would say they don't believe that. They also, cryo lesions take much longer. A standard cryo application is 4 minutes in duration. A standard RF application is 1 minute. And it would be very unusual in cryo to not put at least two lesions at the site of target. And a lot of cryo ablators would tell you that you need to put, 3 to 5 lesions at the site of interest, which of course begs the question of, is it really safer if you're putting 5 lesions in a place where you could get away with one with RF? And there's a lot of debate about this. So just sort of summarizing, we're refining the newer mapping techniques with newer ablation technologies that are, some of these catheters we're using literally were developed in the last 5 years. We have newer surgical approaches with surgery to reduce rates of IART or even to treat it. You've heard of Fontan takedowns or Fontan revisions. There was a big push for that about 10 years ago. It's fallen a little bit out of favor, but is still done and is probably the single most effective way to treat IART in a Fontan. IART is becoming a little less common of a problem because of the newer ways that Fontans are made, which is terrific. We've talked about newer catheter design and technology, and of course, many of you know that I've been a big advocate of low fluoro techniques during ablation and the use of 3D electroanatomical mapping, which has really reduced the amount of ionizing radiation. A typical ablation today, patients getting the equivalent at our lab of about 10 to 15 chest x-rays. Just to give you a reference, until we started using electroanatomical mapping, which allows for real-time observation of catheter movement without radiation, patients would get the equivalent of about 500 chest x-rays during an ablation very routinely. Because remember, the only way to know if the catheter was moving during an ablation was to stay on fluoro the entire time you were administering RF current. And since you normally will give 2 or 3 applications, and because fluoro doses were much higher even 10 or 20 years ago, patients were getting very, very high doses during ablation. So it has really revolutionized the ablation procedure by being able to reduce fluoro through the use of these advanced technologies. So all of these topics we're going to review throughout the year, but I thought it's always useful to start at the beginning, and we'll flesh all of them out in further discussions on EP conference. Does anybody have any questions this morning? All right, I guess if not, oh, Barty, were you going to say something?
No, I just said no questions.
Okay. All right. I hope everybody has a wonderful day, and I'll see you soon.
Thank you.